Greetings from Indian Journal of Anaesthesia. I, Dr. Kiran Mahendru, will give an overview of a recently published article in the April issue of IJA. The article is on the efficacy of ShotBlocker device versus vapocoolant spray for spinal needle pain relief during spinal anesthesia in elective caesarean section. It is a randomized controlled trial. Spinal anesthesia is a well-proven technique of choice for lower segment caesarean section, but the patient refuses for spinal anesthesia because of fear and apprehension of needle pain, being wakeful during the surgery, apprehension of paralysis, and the risk of persistent back pain. Various methods have been used to provide relief from this pain. Now, this study compares these two devices with the traditional technique of using local anesthetic infiltration. Now, one of the devices is the ShotBlocker device, which is a flexible U-shaped plastic device with blunted contact points on the side and a slit in the middle for needle insertion. It basically works on the gate control theory of pain, where it provides non-painful physical stimulation to prevent the nociception. The second is the vapocoolant spray, which is 100% weight by volume ethyl chloride. This spray causes sudden diminution in the skin temperature and thus interrupt ion channel activation and pain perception. The primary objective of this study was to compare the ShotBlocker device with vapocoolant spray for pain relief during spinal needle puncture in primary gravida patients undergoing elective caesarean who had no prior experience of spinal anesthesia. Ethical approval was obtained and the trial is registered with the CTRI. It is a randomized comparative trial on ASA grade 2 full-term primary gravida patients scheduled for elective caesarean under spinal anesthesia with no previous experience of spinal anesthesia. And the patients excluded were the ones with hemodynamic instability, inactive labor, communication barrier or any psychiatric disorder, allergy to ethyl chloride, technically challenging spinal block, ongoing analgesics, any neurological disease, or more than 2 spinal attempts. Now, the patients were randomly assigned into 3 groups: the ShotBlocker group, which is the group SP, the vapocoolant group, which is the group V, and the control group, where local anesthetic infiltration was done in group C. Basic monitors were attached to wide bore IV cannulas were taken, and preloading was done with 10 ml per kg of crystalloid. In the ShotBlocker group, the ShotBlocker device was sterilized with 2% glutaraldehyde, cleaned with normal saline, and placed on the puncture site. It was pressed firmly with the non-dominant hand for 10 seconds, and then the spinal needle was inserted through the slit which is present in this ShotBlocker device. And after the dura puncture, the device was released and the drug was injected. In the vapocoolant group, the spray was applied from a distance of 10 to 20 centimeter for 10 seconds period. It was allowed to dry and then cleaned with spirit and then proceeded with spinal anesthesia. In the control group, a 27 gauge hypodermic needle was used for local anesthetic infiltration. In all the 3 groups, 25 gauge Quincke spinal needle was used in a sitting position at L3, L4 or L4, L5 interspace. A senior anesthesiologist with more than 5 years of experience performed the procedure and gave 10 mg of hyperbaric bupivacaine with 10 microgram of fentanyl, which was a total volume of 2.2 ml. The first spinal attempt was the single shot injection, which was done without change in direction of the needle. The second attempt was the spinal needle hitting the bone and thus prompting to change the direction of the needle. And a failed spinal attempt was the inability to obtain free flow of CSF or dura puncture. The primary outcome of the study was needle-associated pain, which was evaluated using 10-point visual analog scale. The secondary outcomes were number of spinal attempts, overall patient satisfaction, which was measured using 3-point Likert scale, in which a score of 1 was dissatisfied, 2 was neutral, and 3 was satisfied, which was done immediately after giving spinal anesthesia, and adverse reaction were noted. The sample size was calculated based on variation in the VAS score of ShotBlocker group, and the required sample size was 48 patients in each group. SPSS 21 version was used for statistical analysis. The demographic and the baseline parameters were comparable in all the three groups. When comparing the VAS score, which was the primary objective for the pain relief caused by the spinal needle, there was a statistically significant difference between the shot blocker group and vapocoolant group when compared with the control group. And minimum pain was felt in the vapocoolant group, followed by the shot blocker group. Now, number of spinal attempts were more than one in shot blocker and the control group. Adverse reactions in the form of mild redness was seen in the shot blocker group. When the satisfaction scores were compared between the three groups, the patients were maximally satisfied in the vapocoolant group with a percentage of 64.6% who scored the Likert scale at 0.3. In the shot blocker group, maximum patients were having neutral response, whereas in the control group, maximum number of patients, 62.5% patients were dissatisfied. Now, vapocoolant spray is associated with least needle-associated pain, higher levels of satisfaction, and fewer spinal attempts. Skin infiltration with local anesthetic is a common practice which is used during an invasive procedure. Eutectic mixture of local anesthetic is unsuitable for emergency procedures because of delayed onset of 30 to 60 minutes, and needle-free drug injection systems are not a cost-effective method. Therefore, with the shot blocker device, there can be transient mild redness due to the firm compression applied on the device, and this can be a technically challenging process. Whereas the vapocoolant spray is easy to use, but can lead to allergic reactions with ethyl chloride, and it is inflammable. Therefore, they suggest that further research should be done with the potential benefits of combining the angiolysis methods with methods to allay the needle puncture pain for improving the spinal anesthesia in these patients. So both the shot blocker and vapocoolant device can be used to allay needle puncture associated pain during the performance of spinal anesthesia in primary gravida patients undergoing caesarean sections. And vapocoolant spray provides better analgesia and more patient satisfaction when compared with the shot blocker device. Thank you so much.